Anybody from finance and admin logistics?
Yes, we have our admin officer here with us.
Okay, good.
Society.
Thank you. Yeah, I think the key, one of the two key areas are the clinicians and IPC. IPC, very, very important. Not here yet, but maybe usually in the morning they do the rounds and maybe because of that, but we could start the introduction part because it is critical that we need to have representation, or at least as we requested, 2 from each section. The idea of having 2 people in each section is to ensure that there's a continuity in terms of anybody going on leave or sick or things like that. So that's the purpose of us suggesting that there should be 2 people from each of the areas. So let's start off while waiting. And before I start the introduction speech, this is a trial, and now we've been doing a lot of online and virtual training on because of the COVID, and I know it's a new way of communicating and sharing information and delivering trainings and workshops. So if we along the way, if we have a lot of trouble in terms of connectivity, then we will. I just put a notice that we may be able to decide as we go. But at the moment, it looks good, so we can proceed. So yes. As an introduction, I think some people need to mute. All right, we still got Oro there. Yeah, Gibson, you can still hear me, huh?
Yes, I can still hear you.
Okay, so I've been introduced already, but I do quite a little more than just. I'm now the acting manager for these control programs. That means all TB, HIV, malaria, non-communicable disease, and surveillance. We've got 5 units. And then I've been coordinating the FET training or field epidemiology training. In Oro province, we've got 3 graduates. That's Gibson, yourself, Rogil, and Sliwadi. So we got 3 graduates. Though this is not about FET training, the field epidemiology training program, Papua New Guinea is taking the lead in terms of delivering, assisting the response for COVID, but also in preparation for future, outbreaks and epidemics and also natural disasters. As a background, we set up the Provincial Emergency Operations Centers in 2019 and 18 when we had a polio outbreak. And this initiative of setting up Provincial Emergency Operations Center is not only done in PNG, it's a global initiative. And we have the National Emergency Operations Center at the National Department of Health. But for COVID, because the pandemic, it involves wider community, and the declaration of the pandemic, we have moved the operation to the central government building, which they call now the National Coordinating Center, which the police commissioner is the controller and the deputy is the health secretary. As you would read the newspaper today, it's Dr. Downey Esrom is now been the government NEC has approved his deputy controller at the NCC. So in terms of the PEOC, that's where really the nerve center, where the coordination and working together and really see the functionality of surveillance, functionality of response team working, and also in terms of setting up audio video like this. That was what was intended for. Should happen. And to make that office, the Provincial Emergency Operations Center functioning, we need to have the key team leads as a team to support that POC to function. So as a team leads in surveillance and lab and clinical, you are a core team to assist the incident manager to make that office function. And then each team lead will do their part in terms of what action to take when there's a situation. Like I can get an example for Gibson. Gibson will be in charge of surveillance, contact tracing, and then the laboratory comes in to support you in terms of sample collection, packaging, storage, packaging, shipment. So you then take lead in that area, and the lab person take the lead on lab, health promotion take the lead on. But you guys will be actually doing the coordination, and in most instances, you'll be also taking part as the respondents on the field. So we started off the FETP training is just a training to upskill our health workforce in surveillance, in research, in evaluating programs, and supporting outbreaks and pandemics in times like this. So we, the surveillance unit, has taken the lead in terms of trying to support the Department of Health and the NCC in terms of COVID response to deliver the rapid response team training. And we are starting with Oro Province today with on online. So it's also part of a learning curve for us. But do feel free to ensure that you tell us what's happening up there and what your experience are, and what you have learned and what is missing and what didn't work. And we need to be open so that we share and we can learn from this, and we'll be better informed to support you, and also to learn from you to how to deliver this kind of training in other provinces and improve the training materials. So you're free and most welcome to say anything at all, about the way we present to you. So with that little bit of background, so the RRT is actually to support the PEOC, and field epidemiologist training is a special training skills that we give in order to support provinces and at the national level in terms of program management, program evaluation, surveillance, contact tracing, and also to do data analysis, presentations. So I'm happy to say that we got 3 graduates down there. So please, as a PEOC, as an incident manager, as the team of the RRT, do make use of the field epidemiology graduates, because they have special skills, and we would like very much them to the province to use them. So with that, I want to thank the Australian team for the continuous team in field epidemiology training, but also now coming on board to do the rapid response team training. Rapid response team training is not the first in PNC. We had a full-fledged support from WHO as part of strengthening the disease surveillance and outbreak response, but also the provincial emergency operation centers. And we did one training for NCD in 2019, not knowing that the COVID was around the corner. So we had a full day, four days training, which Anthony, my counterpart from WHO, who has replaced Dr. Saisin, has actually came over from Manila, WHO regional office, to help us do a full day, four days training with NCDC. So NCDC is a full-fledged RRT trained team in NCDC. So when COVID came in, they were there. They were the team. We did very little assistance to NCDC. They took on board the coordination in terms of team play and a team working together to activate the provincial emergency operation center, and they moved there. From then on, we just provided, from time to time assistance to NCDC. So that's what this RRT for, is to support the operation of provincial emergency operation center. It's a team that support the incident manager in terms of coming together when there's a situation and describe the situation, analyze the situation, and then dispatch a team to go and do the fact finding, and then bring the report back in, and then and then do the response. So it's we have now cut down the number of 4 days to 2 days. So it's a kind of a compressed training for you. And the way it's been designed with our team is that the key elements of the RRT training will be covered, so that you grasp of the importance of how you should function at the provincial EOC level. And we promise that after the COVID is over, we will come back and do the full 4-day training face to face, so that we can also learn from you what you have gone through this COVID exercise, and also other outbreaks that might come around. So I want to take this opportunity to thank the team that has helped us to prepare this, Joanne and Tambri and James from Australia, and also for Laura, who's listening in, and also our country FATV faculty, James and Gilbert, and I think Rochelle is not online now, but few others, and also our WHO team, technical team here in PNG, to help us prepare this. And I'm excited because this is the first time that I'm going to be sitting for full 2 days, and I want to learn how to do better in the future, because this would be how the training will be delivered in the future, to save costs and also to maximize whatever little resource we have, so we can use resources in a better way. So with that introduction, thanks everyone. Thanks for all those who are online, and thanks Oro. And as I said, if we have difficulty, but don't make it difficult, we need to make it work, because we want to make sure we have assigned these 2 days for you. We want to make it work. That when you have difficulties during the day, then there will be not option, but we'll move you back in a training schedule in the next 6 weeks. That's what we will be like, and we don't want to move you back. We want you to be the first. And having understand that in many fronts, in terms of the administration, we know you have been having problems. We are aware of that. The world is aware of that. We are aware of that. And we want to start off with this FET training to bring together, and you can work together and show health department, WHO, and partners that there are people who can make things happen on the ground down there. So with that, I'll stop here, and I'll allow my counterpart from WHO, Anthony, to say a few words on behalf of WHO and also about the training. Thank you.
Thank you very much, Barry. Oh, sorry, Anthony, please go ahead and share your slides and go ahead.
Yeah. Okay, I think, so thank you, everyone. Thank you, Barry. I think you have said almost everything. Good morning, everyone. Good morning, colleagues. Good morning, participants. My name, as we said, is Anthony Eshafone. I'm currently seconded from the WHO regional office in Manila to support the COVID-19 pandemic in PNG as the incident manager, and also to act as the WHO, that's the World Health Emergency Program, coordinator. So that is why this kind of aligns with one of my responsibilities in those roles. So I bring you greetings from the regional office, the regional director, Dr. Takeshi. I also bring you greetings from the WHO country office, the acting WR, Anna Marston. So as I said, I think the opening remarks by Barry has covered quite a number of my things, but I just maybe want to say one or two things based on the slide that I've quickly put together, and I will be trying to be quick through it, just because I know we did not start on time. So basically, it's about managing health security threats. And we want to know that, as Barry had said, this is a collective work that we need to do to make sure we are safe, right from the much local level to the international community, like we have now seen with COVID-19. So we continuously face public health threats, and this has been on since the beginning of mankind. And these are some of the major events that have happened in history from about 100 years ago with the Spanish flu. And this is where we are now with COVID-19 pandemic happening in December 2020, in December 2019. At least that's when we officially begin to know about it. So it is still ongoing, but even after COVID, what is next and when? So we need to be prepared. This is a brief timeline of public health events that we've seen in our region. When I say region now, the Western Pacific region, which PNG belongs to. And this is a kind of a snapshot of the major ones. So we don't say these are the only ones up to 2019 before we have this big one of COVID that we're now dealing with. So these are some of them. I just wanted to highlight that in these events, PNG is not left out. The ones that have circled from 2009, major ones, we had cholera in PNG in November 2019. We had this volcanic eruption in Cordova. We had measles in September of 2018. Then, of course, from 2019, we now have this big polio outbreak and also an earthquake. So these are kind of the things you as RRT will be prepared to deal with. And this is a good opportunity for you to understand how important your role is in terms of dealing with this. And also, like Barry said, with the COVID-19 outbreak. Another thing I want to take away from here is that the events you'll be dealing with, they are all hazards. In other words, they're not specific to any particular type of pathogen or cause. It could be natural disasters. You look about the earthquakes, the volcanic eruptions. It could be infectious diseases. It could be chemicals or other agents, radiation that may. But every country has those that are its priorities. So just to show you a snapshot of kind of things we do at the regional office to make sure that we are constantly surveying the region, the world, to make sure we pick up what we call the minutest signal that might indicate that something big might be happening. So we go through every day a process of looking at or looking out for information, either from official sources or from unofficial sources. This is also you probably will be doing in your provinces in one way or the other, trying to make sure that you don't miss anything. So we collect this information, we screen them, we verify them, we try to collect additional information, do a risk assessment, and then we respond one way or the other. And that response could vary. And that is where you come in as a rapid response team members. So just to give you an example that at regional office, there are several ways, technologies that we use to make sure we quickly get this information for action. This is the Epidemic Intelligence open source platform, which pulls information from a vast sources that are online and otherwise and put it in a central repository for you to look at. So if you want to quickly have information about anything about the country, all you have to do is to filter down, with some keywords, the country, in this case, it will be PNG, and what kind of sources we are looking at. So that is a very rapid one. And then these information sources, like you will imagine, at the base, there will be so much information for you to sift through, do a risk assessment, and some of them will become very important public health events, and a few will become what we call the public health event of international concern. Even if it doesn't get to that stage, this is how the process, how we sift through to make sure we really know those events that are more important and will require some form of response. I'm sure you are familiar with these two documents, but just to reiterate that in terms of health security, we need to be very familiar with these two documents. The first one is the International Health Regulations. This present iteration came into being in 2005 and came into force in 2007. So that's why we call it IHR 2005. So this gives us the framework on how to manage and address public health events globally. And because this document could be a little bit difficult to understand and practicalize, in the Western Pacific region, we have come up with a translation, I would say, which we call the Asian Pacific Strategy for Emerging Diseases and Public Health Emergencies. So when we look at these two documents, we don't look at them as two separate ones. One is just an explanation or a practical guide to the bigger document. So this is what has been guiding us, and this has been in development and production in our region since 2005. So in APSED, we have 8 focus areas that guide us. The public health emergency preparedness, Betty was talking about the EOCs that have been established. That's what's under that. Surveillance, assessment, and response, up to monitoring and evaluation. But the ones that directly concerns you is maybe this aspect. But mind you, everything is all joined together. So, but just to show that the surveillance, risk assessment, and response is where the RRT in our framework will fit into. So this is just a snapshot of how that is done, how you get your information, you do your risk assessment, and investigation and control. But again, this is where your work will fit in mostly. So in 10 years or more now, this is from 2008 to 2029, just to show you that rapid response team building is a priority in our region. And we have really been able to form these teams in many of our member states. The data here excludes the Pacific, so maybe it doesn't take into cognizance PNG, but just to show you that this is of utmost priority to us as a region. So in conclusion, we want to say that health security threats are inevitable and they are becoming more complex, like we are seeing with COVID. COVID cuts across all sectors of the society and all disciplines. Like Barry was saying, this could have been managed at the level of the EOCs in the NDOH, but because of the nature, it has to be moved into the sector or into a structure called the NCC and be managed by somebody who is not, in the health sector. So that's the kind of complexity we are talking about now. So we know that today we are better prepared, but we are not ready for the worst. So that is why we are investing in making sure that we train you, Oro province is ready to respond to anything that might come up. I've mentioned APSED, which is our framework for health security in our region. Please get yourself familiar with that as a member of the Western Pacific region, especially in the area of surveillance, risk assessment, and response. And we also know that prompt and effective response will help to reduce morbidity and mortality that are associated with health security. Again, like what we know about COVID now, prompt as a detection, testing, and isolation of disease and contact tracing is one of the bedrock to make sure that we are prepared and we are able to respond to reduce morbidity and mortality. So in that note, I want to thank our colleagues, our partners from Australia, Tambri, Joe, and James, and our local counterparts here in PNG for this work. And I pray that, and I hope that these 2 days of training will achieve the aim and we're better prepared, not just in Oro and not just in PNG and globally to meet public health challenges. Thank you very much.
Thank you so much, Anthony and Barry, our chiefs at the National Department of Health and WHO, for those words and the opening remarks. I'll just share my screen.
Joanne, can I add?
Sure.
Yeah, I think Anthony said that this is a non-specific. It won't be like just talking about COVID. And through COVID trainings, there's been a lot of trainings on sample collection, contact tracing, and triads, infection control. They're all the same principle. What this training is about is to make a team work, so the team supports the provincial emergency operations center function, and support the incident manager in terms of processing information and analyzing what's coming through, and deciding what to do as a team. I've been doing surveillance in all my life entire. I started work in Western Islands as a cadet for TB leprosy, and then moved up my way in a short period of time to become disease control officer. And then I was one of the first person to start up the health information system. So it's still in the same area. And then to National Health Department of Health in the disease control and surveillance area. I think many of us, or many at the national level, I'm saying national level again, and also at the province, they think, and there's a culture thinking that when there's a situation, when there's an outbreak, when there's an event, they think it's only the function or responsibility of the disease control officer or the disease control and surveillance unit. It is not, because it involves other people. The labs comes in. The clinician helps us to determine or help us to decide what treatment we could give for what children and adults, and they can also, the infection control officer can come in to say, look, these are the infection control measures for this particular kind of infection. And the risk communication, the most important component is communication. I was in a team, and so everybody plays a very key role, and we want to make sure to see that at the national level as well as the provincial level, we work and address as a team and work together as a team through the national EOC and through the provincial EOC. I think that's the purpose of having this training, to make you work together as a team and decide the next course of action as a team, and each and everyone understand their roles and responsibility to respond to an event, whether it be a disease or natural disaster or whatsoever. So that's the idea. That's a concept. So Team Minoro. So this is not specific to COVID-19, but it applies to every situation, whether it's disease related or natural disasters. Just want to make clear of that. Thank you.
Thanks very much, Barry. Yes, exactly right. So the goal of the workshop, as Barry and Anthony have said, is to strengthen your capacity to deploy as a team, as an RRT, to an outbreak or a public health emergency. Maybe you've already been into the field together. And if not, this workshop is all about preparing you for the next time. So just to grab your interest and give you an overview, these are the broad topics we'll cover during the training. We've divided the 2 days into 4 blocks, and each block has 3 hours of content. The first block this morning is all about your RRT. So what are the roles? What does the RRT do? What is the RRT expected to, or when is the RRT expected to respond to an alert, and how to do a risk assessment. The second block in the afternoon is all about preparing you for the field. So this includes communication plan, preparing a community engagement strategy, and infection prevention and control. And we will ask you to go home and think about a communication plan to come back together tomorrow morning and put one together as a team. On the second day, tomorrow, during block 3, we will cover the RRT response on the ground. So that includes case investigation and contact tracing, sample collection, interview techniques, psychological first aid, and risk communications. And then finally, in the 4th block in the afternoon tomorrow, we'll cover the RRT's role in reporting back to leadership. So situation reports and making reports about how the response is going, how to summarize and interpret any data collected, and the importance of the after action review every time the team does a field response together to see how they can improve the response for the next time. And in each session, we have aimed to provide opportunity for you as the team to apply what you've learned to a scenario in your context. Most of the time we use a case scenario. Sometimes we'll ask you to talk about your experience or your suggestions to any solutions to any problems that we present. So we have many experts that have contributed to putting this workshop and the materials together, and they're going to be facilitating the workshop and present on the Zoom platform over this 2 days. Our experts include Mr. Barry Roper, who we've met, also Dr. Anup from the World Health Organization, Dr. Gilbert, who is one of our senior faculty members for the FETP program, and Dr. Anthony from WHO, who we've met. On the Australian side, we have Dr. Tamri and James. They are senior epidemiologists with many years of international experience, including in PNG. Actually, they're in Port Moresby now with Barry at the Stanley Hotel. We also have Dr. Laura and myself. We're in Australia, and we are both animal health experts. We're animal doctors, veterinarians. And so we like to bring the animal and environmental perspective to outbreak situations. And then finally, some other facilitators have helped with these materials. We have Abel. He's an alumni of our FETP program. We also have Julie. She's now based in London, but was took part in the after action review of the last rapid response team training and contributed to these materials. And we have Dr. Bernie, who will be leading the contact tracing sections of the training and is the contact tracing lead at the NDOH for COVID-19. So before going into the program, let's just first cover our roles as facilitators. As Barry said, we strongly recognize that the RRT is all about working together as a team to solve a challenge. So we haven't been out in the field with you, and we won't be there when you go out. We each do have some field experience ourselves, and we hope to just facilitate you in finding solutions to any questions you have, and help you get to know each other and your roles as a team as we cover the various topics. When we think about what our group norms are during this training and what your role is as a participant during this online training, we do have a lot of time dedicated to group discussion. We know it's tough when you're in a room with just one laptop, but we do hope you can participate as much as possible when we ask for your suggestions during the sessions. We invite you, and we'll let you know. Oh, sorry, I'll just mute this person. Here we go. We invite you to take part, and we'll have this icon, a speech bubble icon on the slide to also let you know when it's time to have a discussion. As Barry said, please be open. Please feel free to ask questions and be open about any concerns you have. We all want to learn from this workshop and feel comfortable without any worries about the environment or about other peers in the team. And so we hope the group now can agree to just keep an encouraging and respectful learning environment. And then you can make the most out of this training and grow as a rapid response team for Oro Province together through this workshop. And just as a note, some topics might come up and we run out of time to address them because we do have a lot to cover, because it's quite a quick and intensive workshop. We can note that topic and set it aside to follow up at the end of the day, or follow up via Gibson in some other way if need be. As Barry said, this is a trial and you are the first province to take part in this training. And we're doing our best to contextualize the training specific for your province and your context. We really value your honest input on how to improve the training so that you and future groups can get the most out of it. So at the end of the course, we will ask you to complete an evaluation. And I think Gibson has handed out a guide to all of you to the RRT training. And the training actually extends beyond this 2-day workshop. You've been selected for this training because you're going to fulfill the RRT duties for Oro Province. And then following this 2 days of initiation to the RRT, you will be required to take part in a field response and complete the outbreak manual that has been given to you as a team, and it will become the manual specific to your province and your team. We'll also ask that you submit an outbreak report and complete an after action review of the field response that you went on with the team. So yes, just to reiterate, this 2 days is just an initiation training. Its purpose is to get you oriented to what the RRT is, how you can work together as an RRT in the province when on and off the response. In future, once COVID-19 has settled down, we will have in-person training where we can really complete your competencies, and we'll conduct a 2-day after action review and scenario-based training. In terms of access to all the resources from today, we're trialing Google Classrooms as a platform. That's where we're going to keep all of the files for you to download. And that's where we'll keep track of you as an Oro RRT as well. You can post questions there. All you require is to have a Gmail email account, and then you can log in and access this platform. So after the training, we'll work with Gibson to make sure you can access all the resources. What you have today is you have the training guide printed out. It's got contact information and a background to the program. It's also got the agenda for the 2 days. You also have the printed out RRT response team manual. So this we hope you can complete during the training and when you're on your next RRT response. And it should be personalized to you and your provincial RRT team. And the aim is that you do submit this manual to your incident manager and to the faculty of this workshop for us to review and approve, so that it can be your resource for the province for whenever you have a RRT response. The other thing you get out of this training is a connection with the FETP network, the faculty that are all on this Zoom, and all the resources on Google Classrooms. Okay, and so this is just the manual, just to orient you. And again, the idea is this manual will be specific to Oro province. And one last thing to mention is we think you'll get quite a bit of exercise actually over this 2 days. You shouldn't just be sitting in your chair. We want this to be interactive. So given how the room is set up, we think it's best if you come up to the laptop whenever you would like to suggest an answer or a comment. And we have the camera there. We can see Gibson quite well and hear him well. So that might be the easiest option, is just come up to the laptop where we can see and hear you give an answer. Okay, so we really would like to meet all of you in Oro. I'm not sure how many in the room now, maybe still about 10 people, Gibson. But what we would like is to find out your name, your position and your RRT role at Oro province, and maybe just describe quickly your favorite photo on your phone and why. So I'm happy to very quickly kick things off. This is my cat, Edward. He's from America. I brought him back to Australia with me. He's the favorite photo I have on my phone. I don't know, Gibson, if you want to introduce yourself, and then we'll quickly have everyone else in the room if they can come up. We would love to see you and meet you.
Thank you. Yes, we have about 12 participants now.
Oh, great.
So I will start off. I am Gibson Kunkene, the surveillance officer. I'm currently with the NPHA, disease control officer. With our COVID-19 response, I'm taking the lead of the surveillance activities. My favorite animal, I think, a dog, but I don't have the picture of it. I can let the other team members to come to the screen and introduce themselves, so I can have a view of them as well. Thank you. Thank you, Petit.
Thanks, Gibson.
Thank you.
Thank you. I'm Champion Sagiri Boys. My name. I'm the acting director of public health. I'm from here. I was here when we actually launched formed the EOC back in 2018 in response to the polio program, and coming from time to time to assist the EOC and this control officer in the incident and then on the team as well. My favorite photo is similar to the one on the screen. I'm from the coast and that looked at like 2 feet. Thank you.
Wonderful. It looks beautiful.
Thank you.
Who would like? Oh, here we go.
Sorry, yeah, good morning. I'm Tora, you bet. And I'm from Oro. Actually, I worked under Family Health Service Program. On COVID, I was assistant to communication and risk communication and community engagement. And so meantime, we are still here. And yeah, we have also plans with you supporting us to continue our programs on COVID and other public health issues. I have any of my best photos on my phone that I like, but my phone is off too, and I'm just wondering. But I see photo on the screen, it's also like my place too, so I love seeing places like that, higher places like that. Thank you.
Wonderful. Thank you. And this afternoon we have a community engagement session. So we will really welcome your input. Do we have anyone else who would like to come and introduce themselves? Gibson in Oro, you're muted at the moment. Need to unmute.
Okay, can you hear me?
Yes, we can now. Yep.
Okay, can you see my team members on the screen at the back?
Only the tops of their heads.
Okay, just wait and introduce yourself, team members. Wherever you are, come a little.
We can hear you though. Yeah, it's easier if you come up.
Can you tilt the laptop a little bit, Gibson? Just tilt the screen down so we can see people.
Oh, that's better.
That's better.
Yeah, good.
How is that?
Yeah, good.
Okay.
Good morning. Can you hear me?
Yes, we can. Oh, now we can see you. Great.
Okay, thank you. I'm Kimberly. I'm the medical laboratory scientist attached with NPHA here. I'm doing contact tracing for COVID-19 in the province. My favorite picture on my phone is my beautiful place, Kufi. Thank you.
Wonderful. Thanks.
Yeah.
Thank you. Good morning.
Good morning.
Good morning. I'm Rogil Bambi. I'm the OIC for our health facility, Sangara Health Center. I'm also under the FET program, and I'm working under the surveillance team with Mr. Kunkene. The best photo I like is, I like the photo of the sun rising. Thank you.
Great. Thanks, Rajil.
Good morning.
Hi. Yes, we can see you.
I am John Duna from Oro. I am the IPC officer, and with the COVID, I'm the first IPC team lead. IPC, I think IPC in our province here. Thank you.
Great. Thank you, John.
Okay, John. Anyone wanting to come in? Come on, Tim.
Good morning.
Hello.
Hi, we can see you.
Yeah, okay. My name is Christopher Mawala. I'm a medical laboratory scientist. I'm engaged with the NPHA, and I'm with the clinical and surveillance in collection of samples, packing and sending. Thank you very much. Sorry, I don't have any favorite photos.
That's okay. Great. Thank you.
Thank you.
Good morning.
Good morning.
Can you see me?
Yes, we can. Yep.
Okay, good. My name is Jetro. Jetro Koimo, and I am the medical information officer to NPHA. And I am currently attached with the contact tracing team, COVID-19 team. I don't have a favorite, I don't have a favorite photo for me, but all the favorite photo that I like is the ones that I have when I was back in school. Thank you.
Great. Thank you.
Hi, I'm Kairini. I am with the Finance and Administration. My favorite photo on my phone at the moment is my daughter's, because she's the only one I have. And I'm excited about this training because I think this is what we need in the province. Thank you.
Wonderful. Thanks so much.
Hello.
Hi.
My name is Elsie Manuda. I'm a health extension officer by profession, based at the medical ward and also at the outpatient area. We're at the point of entry. My favorite photo on the phone is, I have a picture of my two sons. And that's all.
Great. Thank you. It's great to see everyone. The camera's working well.
Yeah, thank you. Yeah, my voice is coming.
Hi. Hello. Can you see me?
Yeah, we can. Yep.
Thank you. Good morning. My name is Rose Kona. I'm a health extension officer by profession. I'm attached with the medical internal medicine unit. And with the COVID-19, I'm attached with communication, risk communication, and also point of entry. Thank you.
Great. Thank you. We'll cover risk communication tomorrow.
Okay, good.
Hello, good morning.
Hi.
My name is Martin Sangai. I am the acting Deputy Director of Public Health with the NPHA here. And on the emergency control, I am in the point of entry. I'm team member to that point of entry team committee.
Great. Thanks, Matthew. Did you have a photo?
Sorry?
I was asking if you have a favorite photo.
No, I don't have a favorite photo. Yeah. Okay, thank you very much.
Thank you.
Good morning, team. I'm Ernest Gitton from Milne Bay. with the family health services in the province. Favorite photos. My this is child. Thank you.
Wonderful, thanks.
Anyone? Oh, Nathan. Oh. Yes, Joan, thank you. I think we are done with your startup present.
Oh, great. We've met everybody?
Yes, I guess everybody.
Okay.
Thank you.
Great, thanks everyone. Really good to see you all and hear about your roles. So I think we're really quite behind in time. I'm not sure we have time to go through everyone on the call. We do have, just to point out, if we haven't mentioned during the introduction, but we do have also Nola from WHO on the call and Emmanuel from WHO, both key assets for RRT training as well. And so also Dr. Alois in Bougainville. So we'll move on to the next session, which is the steps of an outbreak response. And I'll just stop sharing my screen so that Dr. Laura can share her screen and give the presentation.
Thank you.
Thanks. And Laura, are you okay to go ahead? Oh, there we go. Oh, can you please unmute, Laura?
Thank you. I just thought I would just quickly say hello over the video and then I'll turn it off. I'm Laura and I'll be doing some of the presentations, particularly today. I'm a veterinarian and also an epidemiologist, as Joe mentioned earlier. So let me just get this presentation on the screen. Okay, hopefully everybody can see this on the screen now.
We can see the PowerPoint program.
Wonderful.
And then,
yes.
Yeah, so still have to go to presentation mode.
Oh, I should be in presentation mode. It's not working?
No, I can still see the whole
Maybe
program.
not.
Yeah, with all the slides.
Okay. Let me just go, let me just try again.
Otherwise, I'm happy to share as well, if need be.
Okay, how's that?
Yep, perfect.
Great. Okay, so this first presentation is on the steps of an outbreak investigation. And for you as people working in a rapid response team, investigating an outbreak is one of the most common things that you're going to do. And so we really want you to have a good idea of what the process is for that. If I go to the next slide. So just really is the purpose of this presentation is to describe the basic steps of a public health response to a disease outbreak. Now, a few terms were mentioned this morning in this morning's presentations, and I just wondered if you can tell me what these terms mean. So we've all heard them over the past year a lot: outbreak, epidemic, and pandemic. Can somebody in Oro call out what you think these terms mean? I'm not hearing anyone. Everybody's a bit quiet. So an outbreak is a higher than expected number of patients who we call cases with the same disease or similar symptoms. An epidemic can be used to mean the same thing as an outbreak, but it generally refers to a large outbreak over a wider geographic area. The pandemic is an epidemic occurring worldwide or over a very large area. It crosses international boundaries and it usually affects a large number of people. To work out if an outbreak is happening, we need to know how many people are sick, that is, how many cases there are, and compare this to the number of cases that we were expecting. So that's how we work out if there is a higher than expected number of cases. Now, we're going to go into this a little bit further about what these graphs mean, but these graphs are a type of histogram called an epidemic curve, where we put the time on the bottom and we put the number of cases on the y-axis. So here are some examples of sort of cases over time. So here in the first week, there are 60 cases and a similar number the next week. Can anybody call out which one of these or which of these, there could be more than one, they think is an outbreak? So remember, an outbreak is a higher than expected number of cases. Any answers?
Is that C and D, Gibson? Can't quite hear.
It's a tricky question. I know I've started you off on a tricky question.
Yeah, I think all of it, A after D. Some are saying C.
D?
A, C, and D.
A, C, and D? Actually, all of these could be outbreaks. I'm pretty sure somebody said B as well. So so I think amongst all of you, you got all the right answers. So really well done. So outbreaks can be sudden increases above a baseline number of cases. Or there can be gradual increases above a baseline. So for graph A, we have a baseline number of around 50 to 60 cases. And then in week 20, it increases quite dramatically. So that is, a possible outbreak. For graph B, can anybody tell me when they think what the baseline number of cases is? That is the usual number of cases.
Say below 10. Less than 10.
I heard someone say 0. So really well done. So for this graph, we have see 0 in the first few weeks and 0 in the end. So we're expecting 0 or a very small number of cases usually. We sort of see do we see a sudden or a gradual increase in the number of cases? Does it go up very suddenly? Yeah, great. Perfect. Yeah. Okay, for graph C, this is a tricky one. We only have one case. Can someone give me a reason why they think C? For those who yelled out C, why do you think it is could be potentially an outbreak?
Same disease. If the diseases are not common in that area, say for example, cholera, we have one case that's outbreak.
Yeah, I just heard somebody say if the disease isn't common in the area, that's That's correct. Really well done. So for a serious disease, even one case can be considered an outbreak. And an example of a syndrome is acute flaccid paralysis in a child under 15, where we suspect polio. So even one case can be considered an outbreak. And for graph D, is it a sudden or a gradual increase in the number of cases of this possible outbreak? Gradual. Yeah. Great. Well done. So yeah, this for this one, it is over a 1.5 year period, and we do see a gradual increase and then a decrease in the number of cases. We'll go into this more detail a little bit later, but I just wanted to ask you at the start, as a rapid response team, which of the following would you want to follow up further? So A, there's been a sudden increase in respiratory hospitalizations. B, there's been a few cases of diabetes diagnosed. C, one case of an unknown disease. D is looking at ILI surveillance. And E, you have received a call with some people admitted into hospital with fever and vomiting. So can anyone call out some answers here? Where as a rapid response team, would you want to follow up a little bit further, get some more information? E? A, C. Great. I think you said everything. I think I did hear a D in there as well. So for A, you know, it's been a sudden increase in cases, and some people have died. So we definitely want to follow that up. C, we just talked about, if we have even one case of a disease that's serious, it is worthwhile getting some more information. And with E, again, it sounds fairly serious and you know, possible outbreak. With D, I think I heard some people say that as well. If we have a look at the data, we've been seeing 43 cases in this month. But during the same time last year, we saw 48. So for ILI and we may see some seasonal fluctuations. Now, I could have given you a high number of, maybe in a district you do not see 48 cases, so maybe this is a little bit high. Maybe if I said in the country, it might be a little more reasonable, but it seems to be similar to what it was before. So it may, yeah, it may be, I gave you an example of too high number of cases there. So you've identified some reports that you want to follow up further. And when, as a rapid response team, you may receive some information from the surveillance officer, or you may receive an alert. Somebody gives you a call. You read something in a media report, and you think there may be an outbreak. What do you do next? Well, you need to answer these 3 questions, and we answer these questions using a systematic approach. The first question is there an outbreak? And if so, what is the cause? The second question is, what factors are contributing to the outbreak? And the third question that you need to answer is, what priority actions can you take? So these are the 3 questions you need to answer. And we use those using a systematic approach. So in Papua New Guinea, the epidemiologists are taught using an 8-step approach. And even though I'm going to present the steps in the orders 1 to 8, you can actually mix them up. You can undertake some steps at the same time, or you can undertake the steps in a different order. That's no problem. So for the first question, is there an outbreak? And if so, what is the cause? These are the early steps in investigating an outbreak. And the way we do that, This is the first two initial steps of the outbreak investigation to answer this question. So remember all of those graphs that I showed you a few slides back? They all look like they could be outbreaks, but this is how we can confirm an outbreak actually exists. So you get together as a team to better understand the situation. You can make phone calls to different people, look at records, patient histories if possible. You can have a look at the historic surveillance data to see if it is what you're seeing is expected or it's unexpected. And what these things do is it helps us confirm before we deploy to the field, before we do anything more, it helps us try and confirm if we are seeing a higher than expected number of cases of the same disease or syndrome. So it's not due to increased reporting or increased testing. Now, sometimes you will not be able to confirm this and you actually will need to do a field visit if you think it is sufficiently serious. If there's an outbreak, it's also important to know what's causing it. It could be a pathogen, a chemical, or some other hazard that is causing the situation. For you, most commonly, it will be a pathogen, and at the moment, the pathogen is COVID-19. So sometimes you'll have this information straight away because some specimens have already been collected and sent to the laboratory. But in some cases, it will take a lot longer to work out what the diagnosis is, and that's okay too. We can describe what the disease looks like without knowing exactly what's causing it. So that's the first question. And if you've received a possible report of an outbreak, and as a rapid response team, you've collected a little bit more information, you've made some phone calls, you've looked at the historic data, you've looked at the medical records of a couple of patients, the laboratory may have identified a possible pathogen, you think there is an outbreak. What do you do next? So you think there is an outbreak, and you need to decide, whether or not to conduct a field investigation. You need to prepare for that field investigation if you decide to go. And you also need to think about who should be on your investigation team. So it's not possible for you as a rapid response team to investigate every possible outbreak. You'll need to be able to use your judgment about whether the outbreak is serious enough to go for a field investigation. And we're going to teach you some tools in later presentations about some tools which will help you make this decision. Some examples of when a field investigation could be needed is when there is a new illness reported in the community, where there's a rapidly increasing count of cases, where there is severe illness and death. So once you have decided, yes, you will go for a field investigation, can you tell me how you would prepare for it? Can somebody in RO please call out some ways that you would prepare before you go out for a field investigation?
In most cases in the provinces, you will if there is a reported case from a remote district, you have before you go out, you need to find out the person who's actually reporting the case. And
great, yeah.
And also you need to know where it's actually coming from, and the area of the sketch down that maybe the map of where this report is coming from. In most cases, those reports are non-medical people talking, so you need to really find out things.
Great. So you need to speak with some people who work in the local area, the person confirming what the situation. You need to know where you're going, have a look at a map of the area. Is there anything else that you would do to prepare for a field investigation? Maybe the IPC? If you have any other suggestions?
Before going on, we have to form a team of experts. I might go to the field and meet someone, like a lab specialist or someone. So I have to have a team ready to go out. Before going, I have to have a team, full set of team.
Yeah, so you assemble the team. That's terrific. And you also speak with the laboratory person. I imagine you collect some supplies as well. So that's terrific. There's some great responses there about collecting supplies. You can also organize some logistics like your transport, and you assembled the team as well. So really well done. Now, that third question, who do you think should be in your investigation team? What are some roles that you think should go out with the rapid response team?
In my team, I should include the clinician, lab person, collect the sample, a clinician to make a diagnosis, maybe the physician on the ground, and then the surveillance team, and
Perfect.
awareness team too.
Yes, great. Terrific. Okay, so I think that's terrific. So we have somebody from a clinical background to help make the diagnosis, somebody from a laboratory to help collect the samples, somebody involved in surveillance, and somebody involved in risk communication. So that's terrific. So you've decided to deploy and you've assembled your team of people. Some others you may consider are specialists in environmental health or animal health. It really depends on the disease that you're working with. So you've assembled your team, and the next question you need to answer are what factors are contributing to the outbreak. So before we go any further, what is a contributing factor? What do I mean by that? Well, these contributing factors are factors that can cause an outbreak or make an outbreak worse. So for example, with a foodborne outbreak, contributing factors could be contaminated ingredients, natural toxins, a food handler who is ill, insufficient cooking. There are many causes or many many factors that could contribute to the outbreak. So if we had a COVID-19 outbreak among healthcare workers in a local hospital, what do you think some contributing factors could be? Again, if you could call out some answers. So if you detected a COVID-19 outbreak in one of the healthcare facilities, what do you think some contributing factors could be?
Insufficient PPEs, no much awareness made, no active IPC practices. Yeah.
Great. So that actually was some really great examples. If there is a lack of IPC or not enough PPE, it can definitely contribute to an outbreak among healthcare workers. If there isn't enough awareness, or if if potentially the procedures aren't followed, even if people are aware of them. And then of course, people attending work while they're ill is another thing that could contribute to the outbreak happening. So to answer question 2, we conduct these 4 steps, and this is where the epidemiologist or surveillance officer and your team can really help you with these steps. So step 3 involves working out some criteria for which people can be considered cases, and this is called a case definition. In step 4, you use that case definition to find additional cases and collect more information about them. And that is really to help you identify what those contributing factors could be and describe the outbreak. In step 5, you write all the information that you collected about each case in a list. So one row is one case. And then in step 6, you have all of this now information about the cases in your outbreak, and you describe and interpret these data. So we're going to go into some of these steps in later presentations, but this is where really the epidemiologist can help you out to collect those additional pieces of information. So the last question that we want to answer when we're responding to an outbreak is, what priority actions can you take? And even though this is the last question and the last steps, remember that you can do this at any time during the outbreak response. And it really, really should be started at the beginning, and continue through until the outbreak is over. So for question 3, what can be done to help? Well, you can implement some control measures. And really, they can be very general when you first respond to an outbreak, because perhaps you haven't worked out what is causing the outbreak yet, or you don't understand how it's being introduced into the community or the population that you are investigating. So later, when you work out more information, and that's where the epidemiologist can analyze the data and tell you what some of those contributing factors are, then you can recommend more targeted measures. You can make some long-term recommendations that can't be implemented straight away, but could prevent outbreaks happening in the future. But control is really more than that. We also need control measures which community and health officials understand and support. And they also need to know, the community that you're working with need to understand what's happening as you go and investigate the outbreak. So it's really important that you engage with many different people through the process and keep them updated and informed. So this is not just a last step, but should be done throughout the outbreak response. So this is what you can do to help. You can implement some control measures, and you can communicate with the people that are affected and with your colleagues in the health department. So remember, when we're investigating outbreaks, you need to answer these 3 questions. Is there an outbreak? And if so, what is the cause? 2, what are the contributing factors to the outbreak? And 3, what priority actions can you take? We answer these steps using a systematic approach, so you don't miss anything. It's an 8-step approach, but they do not have to be completed in order. And outbreak investigations are really what epidemiologists are trained for. So they will commonly lead the outbreak team and can help you while you learn these steps in a little bit more detail as you go and investigate some outbreaks. Now, we've included this pocket guide in your training package. You'll need to make some cuts. There's some instructions to fold it up, and it will turn into a little book that you can put in your wallet and take along with you when you investigate outbreaks. Are there any questions?
Any questions there, Gibson?
just a comment on the question, a comment on the formation of the investigation team. Before a team goes out, we need to know the outbreak itself. What is the disease itself? So you need to prepare the team to go out to investigate. If it's like a measles outbreak, then you need to form a team according to what is needed to be taken out for that particular investigation. Surveillance form, or maybe if you need to take some antibiotics, those are some of the things that you need to while on a team going out. We really need to know what is the disease outbreak itself. Thank you.
Yes, absolutely. Because you cannot investigate every outbreak. And there are some tools that we can show you later on, which will help you make the decision about which outbreaks to go to.
Yes, and it's a nice transition to the next session because we will talk about the team now and getting the team ready. So I'll just, oh, actually, Laura, can you please share the next session?
Yes, absolutely.
Thanks.
Just give me one moment.
So thanks to Laura for giving our first talk with all the content. We know it was a lot, covering all the steps of the investigation. This is to orient you to what a response is about. And now through the workshop, we're going to touch on these steps, starting now with the actual RRT team, the roles and the responsibilities and who is part of the team. So again, through this session, we're going to ask everyone to provide some answers, and Laura will type your answers onto the screen so we can see them. And we really appreciate everyone so far being very engaged and part of the training.
Can you see it on your screen, Joe?
I can't. I can, no, it just says has started screen sharing.
Oh.
Can anyone else see it? I can't.
I think it's going to come on, I guess.
It's still loading?
Yeah, I think it's loading because it's saying started sharing, so let's give you more.
Don't know, Laura, if you can try exit and try again.
Yes, I might try doing that. Give me one moment. Lovely technology issues.
Yeah, otherwise I can do it. And after this, everyone will have a break for morning tea. I'll try and we are an hour behind just from starting a bit late, but hopefully this will not take too long.
Okay.
And then we can have morning tea.
Okay, can you see it now?
Yes.
Perfect.
Great.
Yes.
Okay. So we're going to talk about the RRT itself, the team and the different roles. Now that Laura's walked through the whole outbreak investigation steps. So at the end of this session, you should be able to describe the background and the purpose of RRT, describe the various components and the roles in the team, and recognize the importance of establishing connections between your team and other expertise that might be in the province, in the health authorities. And to continue to make those connections and in your manual, I think it's on page 6 to 9, there's space for you to fill out the different roles in the RRT and gaps for where you can put in the other experts in your province that you might reach out to for help through an outbreak investigation. So essentially, we're going to get to the bottom of what is an RRT, why do we need the RRT, and who is part of the RRT. Next slide, please. Great. Okay, so first question to the group, and Laura's going to type your answers into the slide. What do you think the RRT is? I think you've had some hints already. We've had Barry and Anthony present on RRT. But anyone want to suggest?
RRT team is the team that responds immediately to any emergencies or any call that comes in response to somebody's writing.
Thanks, Gibson. Laura, maybe just type in PowerPoint program. Yeah.
Yes.
Yeah.
Can you see the PowerPoint program?
Yeah,
Yes.
Yeah.
Okay.
Thanks. Yeah. So it responds
Great.
immediately to the public health emergency. Perfect. Anything else? Anything about the makeup of the team?
It's also purposely to assist the incident manager and the whole EOC team.
Assist the EOC team is the response that's coming.
Great. Okay. Any other answers? Well, you've ticked off a couple that I had, and we'll move to the next slide with some more suggestions. Oh, yeah, you can just stay. Yeah, that's perfect.
Yeah.
Yeah. So I guess you got the ready to deploy rapidly, ideally within 24 hours of confirming an alert. And yep, trained and equipped under the EOC to help the EOC. I would just say also made up of many different disciplines and expertise. As we've covered before, we have surveillance, clinician, IPC, laboratory, risk communications, and community engagement. So the team is a multidisciplinary team. It's not just an epidemiologist or a clinician, and often is coordinated with other response efforts. Okay, so the next question is, why do we need a RRT? Again, please, can we just have some suggested answers, and Laura will type those up.
To stop any outbreaks from happening.
Yep. Excellent.
To stop any outbreaks from getting worse.
Yes, exactly, to stop them getting worse.
To respond quickly.
To respond quickly.
Quickly and to mitigate the problem of the outbreak itself.
Terrific. Communicate the problem of the outbreak. Did you say communicate to who? Sorry?
To respond quickly and to mitigate the problem.
Oh, mitigate the problem. Terrific. Okay, well, let's have, yeah, I think you had the answers that I had. So we want to decrease the disease and any deaths as a result of disease. And we need to do that. We need to have a team that is trained and ready to go quickly for an effective emergency response. That's the key to the RRT as well. And also, the national authorities don't know exactly where the next public health emergency can happen. So in the province, it's great to have a team ready to go out and work together to respond to the outbreak. Okay, third question. Third question for the group, who is in the RRT? So we have talked about a few roles. I actually have a list of 10 roles here, and I'm wondering if you'll be able to get them all. Who might be in the RRT?
Team of multidisciplinary experts and clinician, multidisciplinary experts, yeah.
Yeah. Okay, yep. And a clinician.
Clinician, surveillance officer, environmental officer, laboratory guys. Risk communication or social worker to help with the communication. What else? Who else?
It's quite a few already, but there's still a few more that would be very important as part of the RRT.
Operators.
Operators.
Doing your operator.
Who would help organize the team to go out and make sure they have everything they need? Finance.
Finance, yeah.
Yeah.
Logistics.
And logistics.
Yeah.
Excellent. Great. So that, yeah, you did cover a lot of the key roles. There's a few more. There's the team leader who can be fulfilling any of those roles, maybe even the multidisciplinary expert, but there's always a team leader. There's the infection prevention and control, like John, of course, and other more specialized roles, water sanitation and hygiene. There's the veterinarians, the animal health people like me and Laura. So I guess, yeah, the main message is that there can be many roles and experts that can join the RRT, depending on what's needed. The key roles typically that you have there today, the team lead, the clinician or case manager, the surveillance officer or the epidemiologist, the lab expert, the logistics, and the finance. Very key. And then additional roles as needed. Okay. So now we've covered the what, the why, the who the RRT is. Let's talk about what the RRT does. What activities might the RRT do? And what are some of the specific responsibilities for some of the roles? So let's think of at least 5 activities, maybe, that the RRT would do when they're out in the field responding to an outbreak. And just the next slide, sorry, Laura.
Collection of data.
Yep. Some other things that Laura might have covered in her talk.
Case finding.
Yep.
Maybe the disease, you probably need a clinician to maybe start after while doing the interviews, diagnosing and treatment of their patients needs to be treated.
Terrific.
Drop case definition and line listing.
Dr. Gilbert, thanks. Dr. Gilbert has said, please, Oro team, do not hesitate to answer any questions or feel like you might get it wrong.
Okay.
Please, just opening the rest. Now is the time to make these mistakes and get the right answers before you go
Yes.
out into the real situation, and then you'll know what to do. And please ask us any questions, clarify anything. So very true. Thanks, Dr. Gilbert. Yeah, and you are actually suggesting many things that are in addition to what I have here. So I'm learning even more about what you might be doing out there. It's really nice. What? How about in the community? What might you be doing? Yes.
Collection of specimen samples by our scientific officer, lab scientific officer.
Yes, perfect.
And referral of if we have severe cases down out in the field, we need to refer them to the nearest health facility.
Awesome. So you have a lot more than what I even had on my list from the standard operating procedures. So yeah, you've covered a lot of the activities. Looks like maybe the only one missed would be supporting any training and capacity building in the community and some interventions, like Laura mentioned, as part of the outbreak control. But other than that, risk communications, rapid deployment, investigating alerts, conducting interviews, taking samples, all of that is part of the RRT activities. Okay, so next, we're going to look at each of the roles, and please suggest just a couple of responsibilities, just one or two for each of these roles. And we'll start with the team lead. What would the team lead need to do when out with the RRT?
Organize the team.
The team ensures that there's enough materials needed for the particular team to work.
Sorry, I didn't catch that one. It's a bit far away. Are you able to let us know, Gibson, or come closer?
Ensures the team has enough logistics. I mean, the logistics needed adequate.
Okay. How about, we'll move on. What about the epidemiologist or the surveillance officer? What are some roles that they would have to do?
Confirm case definition.
There need to be, the case out there reporting. Confirm the outbreak.
Before that, the case definition, also the epidemiologist will need to draw up a line list in the spreadsheet or something for the team to.
Organizes the line list. Yep.
Line list in here.
interpret the data.
Interpret the data. Excellent. And since they are, they have been a graduate of the FETP program and have some training in data, maybe they also manage the data too for the team. Great. Well, so I have a few more extra things. So for the team lead, one of their main jobs on the RRT is going to be to report back to the PHA. So they're the responsible point of contact to let the leadership know how things are going and how they're going out in the field with the team. As you said, organize the team members, ensures a coordinated response amongst the team members. And yeah, just is the point of contact for the team as well. And we'll go more into this with the communication plan, but they get the information from all the team members every day to collate into the report back to the leadership. For the epidemiologist, we touched on this with the outbreak steps. They have many responsibilities because this is one of their big areas of expertise is the data collection and informing the outbreak response. Like you said, they interpret the data described by people, place, and time, try and note any trends and any contributing factors to the disease and inform the interventions. So in your manuals, these roles, there is a list of the comprehensive responsibilities for each role. This is not an exhaustive list, but it's just to give you an idea of what each team member would be expected to do out in the field. So next roles, we've got the case manager and the clinician. Who wants to suggest some what the case manager or the clinician might be doing as part of the RRT? And it doesn't have to be the clinician on the team there. Anyone can suggest responsibilities that they think. As Dr. Gilbert said, now is the time.
Clinically.
And feel free to come up because we can't hear all what everyone is saying. So either you could come up and we can hear, or Gibson, maybe you can let us know what everyone's suggesting.
As a case manager out in the field, you actually attending to any sick patients there, seeing and interviewing them, and at the same time doing diagnosis and doing
Great.
actual treatment. A patient needs to be referred. Then to arrange for referral.
Arrange for referral, yes. Jobs on the RRT is going to be to report back to the PHA. So they're the response. Sorry about that. I just muted James. Okay. Terrific. Some additional things I can think of. They might help the epidemiologist with deciding who's a case and who isn't. Do they have the clinical signs and other criteria that might meet the case definition. They might be the one to inform anyone in the community of laboratory findings and explain the interpretation of laboratory tests. And they might also help with infection control. But you definitely got the main things there. They attend to the sick patients. They help with the diagnosis out in the field. How about the laboratory expert? Maybe you can let me know in Oro Province. Is the sample collector usually the laboratory expert or the clinician or both? Both?
Both the laboratory officers as well as the clinicians.
Because in the hospital setting, you have the laboratory person around to assist in the collection of the samples. While in the outstation in the rural facility, they don't have laboratory. Not always a lab man is there. It's a health worker, maybe a nurse there to collect the sample. He or she's been trained to collect samples. So he or she would be in a position where she will be collecting samples when necessary.
Great.
Sample collector also decides which type of samples to collect, and then the transportation of the samples.
Responsible for preparation and transportation.
The safety of the
Excellent. So the lab expert will also probably support the protocols for the collection and for the transport as well. Any quality control of the samples. And other than that, I think you've got them. I would say if there's a need to touch base with the central lab, they would be the point of contact often as well in the response. But you guys are definitely getting the major roles, which is terrific. Okay, next two roles are extremely important for the RRT. And I think a lot of people forget about communications and logistics because there's a focus on some of the more technical data and clinical and laboratory aspects. But communication with the community, communicating back to the province leadership, and actually organizing the RRT and getting them off the ground, out into the field is really important. Let's start with communications. What are some roles for the communications person on the team?
And so the booklets or pamphlets regarding the issue is readily made available.
Yep. So get the resources, the pamphlets and messages for the community.
Yes.
Any other suggestions?
Engagement of the community.
Yep. Yes, engaging with the community. And we'll cover this in the afternoon, where we will talk about the methods and the importance of engaging with the community. But yes, and this, this is something that can be done before going out on a response. The person that has the communications and engagement role or the social mobilizer role, they can start early with forming trust and relationships with the different districts and the leaders and other key stakeholders in the districts, and engage with them when needed on a response. Great. And how about for logistics? I know you do have someone on the team for logistics, which is terrific. And what are some of the responsibilities they have for the RRT?
Ensuring all resource vouchers and pamphlets, all resources are available for the communications.
Come closer to the screen.
Yeah, so managing what items the team will need to go to the field.
Yes.
Great. Anything else that the logistics person will need to do?
Organize transportation.
Perfect.
Keep records of the logistics that have been distributed to the team members.
Very good mixing to the site.
Great. Yes, keep an itinerary or records. Exactly. What else might they help the team with, especially if they're out in the field?
District office ensures money is available.
Yeah, funding, money. I think you've definitely covered all the key points, and the only other thing is helping set up communications. Often the logistics will have to do that too. Great. So I won't go through this list because you really did touch all the main ones. Responsibility for communications, responsible for engaging the community, the key leaders, and we'll go into this in detail today with Abel. Disseminating the information in the form of pamphlets or other resources, helping make the recommendations and coming up with the talking points or the key communication points as well for public health recommendations. And then for logistics, just like you said, help with the transport of the teams, all the materials that they'll need, especially personal protective equipment, vaccines, medicines, communication equipment, and the funding as well, and any other support that they might need. Okay. We've just got a couple more roles to cover. Hopefully these will be quick, but these are really important for the safety of the team. And we will go into detail about infection control later today. But I just was wondering if you could suggest maybe 2 or 3 responsibilities for infection control.
You see. Ensures IPC infection control measures practiced within the hospital setting or within the health facility, and also everywhere.
Yeah. Yep. So they are responsible for the protocols, the guidelines. Yeah. And the team sticking to the protocols. And how about the equipment and the personal protective equipment?
They work in close with the logistics to ensure all of the PPEs and personal equipment are readily available.
Yeah, exactly. Yep. Yeah, so they can help logistics by informing what equipment the team will need. Okay, and how about for WASH, water, sanitation, and hygiene? This might be something that the clinician and the IPC person also take responsibility for. But it's also an important area to address. So what I have here is identifying any common sources of water supplies and checking in about access to water too. And this could be important for COVID-19. You know, we need to be able to wash our hands with soap. So just ensuring that access and the protocols around hand washing. Yeah, so and the WASH person, it can be very important in certain outbreaks that are waterborne, like for cholera, which does happen in Papua New Guinea. So would be very relevant in an outbreak situation where there was concern about water contamination. Okay. So the last question is, are there any roles that I've missed today? That I've missed? I think we've got everyone, but I was wondering who in Oro is the finance officer and if they can suggest some responsibilities for the finance officer.
Finance officer, yes. What do you want the team to be with?
Ensuring that all the payments for the team is ready to work. The travel, the food rations.
Joanne?
Yep.
Yeah, Barry here. Just trying to see other roles. He's, I think, the most important person in the overall EOC and also the function to support the function of the RRT would be the incident manager. The incident manager, I think, is the person who runs the whole show, who keeps the team together, who makes sure that decisions are made consistent with the resources. He is probably the closest to the CEO. So in this case, for the COVID as well as for the polio response we had, the director for public health in many instances are the incident manager or the director for clinical services. We encourage incident managers, whether it be the director of public health or director of clinical service, to take the lead because it's the next, next level of decision making. That's a member of the SCM at the provincial level. So whatever decisions or agreements made in terms of finance or logistics or given directions is made in that room. Because if we have only the rapid response team members in, then there will be a gap of miscommunication and also misdirection and also delay in moving the team out to do investigation whatsoever. So there has to be always an incident manager to oversee the operation of the rapid response team under the provincial EOC. Let me clear all line, Laura. So, Joan, sorry, I was speaking in Pidgin now, Melanesian Pidgin.
No, thank you so much, Barry. No,
Support to the
it's a very important. And Gibson, is the incident manager there today?
No, the incident manager is not here, unfortunately. He's
Okay.
sick. I had his sick.
Oh, sick. Okay.
Is the, as we had in the morning, in the introduction, in the absence of them, is the next incident manager. So he's actually the incident manager now.
Okay, thank you.
Am I right, Gibson?
Yeah, we'll take it at that in the meantime.
Anyway, I'm not trying to impose a title on you. It's up to you.
Great. Thanks very much, Barry. Extremely important to point out. And I think we were saying the finance officer ensures the team is funded for travel.
That's right. And so fundings are readily made available according to the plan or that has been put forward.
Yeah. Yes, perfect. Okay, have I missed any other roles?
Yeah, just if I may again interject on here, the finance officer and the logistic officer are very key to the deployment of the team. We can have the best plan and also in terms of doing a budget and what equipment should take and who the team players will be. But if the logistics person and the finance officer do not understand this process, that we need to move in time, because there may be a situation where we might not know the cause of the outbreak or the whatever is causing the situation in a remote settings. So in terms for a team to move, the time that the finance officer or the admin officer puts in to ensure that the paperwork is done so that the bosses can sign and so we can run down to the bank and get the money and go is very crucial, very important. We may have the money in our account, but those processes do take time. And that's why in the RRT team, we want to make sure that these guys are very, most times we look at the clinical medical doctor, HCO, nurses, and surveillance officers, they are there, but you can't move unless these guys help you to go. So make them look important. They are really key in terms of making you go out to the field.
Absolutely, very true. And we have Gibson in the room. Do you have the finance and logistics officers?
Yes, we do have them.
Excellent. Yeah. Very critical to the team.
Yes, the finance personnel is saying the important function that they do is the reporting back by the team that have gone out there with the funds that with the reports after the activity, they have to update and report back to the finance officer.
Yeah, I just want to add also that the idea of the training is actually to make sure that the structures are inbuilt within each PHA. So at the beginning of the year, when you're doing your annual plans, you already have budgeted some amount of money aside. So when you have an outbreak, you know where to go, and I guess the finance officer will know that there is money also already there. So I think the process will be much quicker. So at least having the structure built into each of the PHAs is probably will be like the best thing to do after these trainings.
Thanks, Abel. Yes, wonderful point. So the finance officer there can work with you, with the team and with the incident manager to make sure there is a plan for funding any emergency response for the RRT. Okay, well, we'll move on to, there are a few other roles to consider, and these might be pulled in to the RRT depending on the outbreak, depending what the emergency is. Maybe it's a natural disaster, maybe it's an outbreak from animals or mosquito-borne disease, or other disasters that require psychological health expertise. So here's just a small list here. It would be good to work out in your province, or maybe even in other provinces, who you can call on to assist if you need to for an RRT response, if you need this additional expertise. And in your manuals, there is space to add these other roles and any other experts you have in the province that you might seek help with the response. Okay, so and next thing is to remember that you don't have to have 20 people on the RRT. You have got at the moment 8 to 15. So, you know, we're talking about all these different expertise areas and all this multidisciplinary team. Often that is impossible. Many of the RRT members can actually fulfill multiple roles. So someone is always a team leader. It could be the clinician, it could be the surveillance officer. Depending on the outbreak, it could be the environmental health expert. It just depends what the response is. Sometimes there's overlap, the clinician and then infection control, the laboratory expert and the sample collector, that sort of thing. So think about what roles you can cover that are outside your typical role. You have a role now, but think about what you can cover outside that role, or what you would like to enhance your skills in. So just something to think about. And that's the end of this session. So this is all about the overview of the RRT. And this is just a summary of some of the key messages to take away. I know we did cover a lot about each role and the responsibilities, but to take away, you as a RRT are essential for a response. You should be ready to go if needed, or have a backup person for your role, ready to go if needed. To be effective, your team needs to be equipped and supported under the EOC in ORO. Key thing we want to highlight is the RRT is multidisciplinary, multifunctional, many different roles, and you might need to have other experts that are available to reach out for advice or to come with you on a response. So after this training, you can network and find out who else in the province you need to engage with. And as we said, the RRT really should be ready to go within 24 hours of an alert. So we'll finish here and let you go for a break. After this, we have got 2 sessions with Laura, and we'll cover first the verifying an alert, the steps to take, and how to guide you as a RRT as to whether you need to go on a response or not. And we'll cover risk assessment as well. So hopefully you have got your morning tea there. Gibson, was it?
Joanne,
Yep.
I just have 2 comments to add on.
Sure.
One is about the RRT should respond within 24 hours. That's also a national indicator, and also a global set indicator to measure whether our response system is working or not. And by the international IHR, what we call international health regulations, and within that framework, countries are to show that we are responding within 24 hours. So in terms of response, sometimes we think that having the physical presence where the event site is, it really doesn't necessarily mean that. Now, once we receive a message of any event out there in the community, responding could also mean making phone call and giving advice to the person who's on the ground. In the past, I think over many years of my experience, is that when we get the sort of alert, we put the requisition in and we put a plan in, and until we are given the money, the allowance, and to go. That's that's when we are on the ground. That's when we go. So I think respond. The word respond doesn't really mean that we have to be on the ground. Respond meaning that you can even respond by way of advice through the phone call, telling them what to do, what to prepare, what information you need. So that's, I'm just trying to make clear, but it's an international, standard requirement for states or countries or areas, whether it's been in the province level, to measure against. That's in the national health plan, in the last national health plan, and it will be in the national health plan in the next 10-year plan. That's one. Two is in terms of multidisciplinary, we also need to consider that a lot of our health facilities are run by churches in our communities. Make sure to involve them right from the beginning when you have an outbreak in the community, because they have a better communication system and better communication response system, I guess, than us, the government, and many other organizations. My experience is that the church do play a very important role in terms of disseminating information, and also the response that we can get from the community when we involve the church leaders are far better than us, the government. And also with that, either you got a bigger company there in the oil palm, depends on where the event is, but I think churches do play a very good role. Even though in this difficult time of fall, not every villages are covered, but churches seem to find a way. They still have these two-way radios still functioning in many places when we have done our with it. So those are my two comments. Thank you.
Thanks so much, Barry. And I think we will have some great discussions about that engagement and with the churches with Abel's session this afternoon on during community engagement. So thanks so much for those insights. What we'll do now is if everyone can just take a 15-minute break. And I think you have some other morning tea there, but just 15 minutes. We are a little bit behind time, but we're hoping that we can make up for some time in the next sessions which Laura will lead, and then have lunch from around 12:30. But we'll see how we go. But if you just can take a break now for 15 minutes and come back, or even a little bit shorter, let's be back by noon, if that's okay. And sorry to keep it short, but we want to get through the day and make up for some of the delay this morning.
Okay.
Thanks, everyone. Have some energy and sustenance, and really look forward to the discussions after the break.
Thank you.
Thanks, Gibson. We'll see you at 12. Hi, Gibson. Is everyone back in order or give it a few more minutes? Oh, actually, it looks like we've lost Oro.
Hi everyone. We're trying to get through to Oro, but we can't. So the phone's not going through. So we're still trying.
Okay, thanks, James. Thanks for the update.
Maybe they've run off for lunch. We think. But
Oh, we're wondering about that.
James, that was my worry.
yeah, if lunch got brought in, they.
Yeah. No, that's fine.
We'll keep trying to connect, and if lunch has been brought to them, then yeah, we'll just
pick up at 1 o'clock or so.
Reconvene at 1 at the latest. We'll let you know if we hear anything.
Yeah, I mean, even if we start at 1, so Laura has got an hour allocated, but it might not go for that long. Depends on the discussion. And we allocated a lot of time for the community engagement, 30 minutes of discussion. So that might not take too much time. So, and I can cut down IPC. So I think we'll still be okay to finish by 5 if we have our lunch until 1 and still have a break and everything. Oh, okay. Yeah, okay. Yeah, sure.
Joe, probably also check with participants. Some may have, taken a bus ride or may have come from distance as well, and 5 p.m. might not be okay for everybody.
Yeah.
So ensure that the audience is able to stay up until that time. Over.
Thanks, Abel. Yeah, we really wanted to be done by 4:30, so we'll keep an eye on time, and I'll just move IPC or just provide the resources, depending how we go. Especially the COVID presentation, they've had, I'm sure, already, and have the resources.
Yeah, that's one other thing also, is as long as they have the materials, I guess just placing emphasis on where there needs to be, and then I think just running through the materials as quickly as we can.
Yeah.
So we cover everything for today.
Sounds good. Well, very happy anyhow that we got through block 1 with no interruptions to the internet. It's great.
It's been done very successfully. I really enjoy the sessions very much.
Oh, thanks, Alois. Yeah, no, they've been really great, very engaged. Even all in the one room and one computer, it's really good.
So we got through to them, and their lunch has arrived, and they would like to have it and start 1 o'clock sharp, if that's okay with everyone.
Yeah, no, really glad it arrived. I think they were having chicken or something from what I saw. So
Yeah, we
they
can't
want
really-
to have that when it's hot.
Yeah, and he's just loading up the credits that we sent through, so they should be all good for the afternoon.
Okay, great. Well, let's all reconvene at 1. I'll add that to the chat.
Sounds good.
And we'll still have an afternoon tea so they can have, because I know that they got some drinks and things. Yeah, and we'll just see how the afternoon goes.
That sounds good, Joe.
Thanks,
and just
everyone.
remember
Sounds good, thanks.
stop the live YouTube.